On the behalf of Department of Family Medicine, I welcome you all to the discussion on the verdict by Honorable Highcourt of Kerala regarding the PIL for family medicine. It gives me immense pleasure to welcome Dr. P K Sasidharan, former HOD of Department of Internal Medicine, Government Medical College, Kozhikode, and Emeritus Professor, Department of Family Medicine, to host the session. It is his effort, along with the other members of the SHOM is an organization, Social Health, One Health movement, that led to the verdict. Thank you, sir, and over to you.
Very happy to be here to discuss the background and the issues which led to the public interest litigation and the favorable verdict that we got. So let me share the screen. Can you see the screen?
Yeah.
Hope it is visible. Oh. This is the title of the discussion today. But in the beginning itself, let me clarify this one particular point. The statement, the names, family doctor, general practitioner, primary care doctors, or doctor of first contact, all mean the same only. They are not different. There is confusion regarding the nomenclature itself. So that has to go. And only we can do it properly. And I declare that I have no conflict of interest. I have nothing to disclose. I have nothing to sell or nothing to market, except that I promote the concept of family medicine or family practice. And I do not have any personal gains by doing it. It's simply out of objective of social health. And if at all, I have only financial loss, which I happily do it because it's for the next generation. This is what happens now. Wellness or happiness, one should know that it's a social issue. Like when you say sound mind in a sound body, sound individuals are possible only in a sound society, or healthy individuals are the manifestation of social health. It's an issue of social security and human development. And that should not be reduced to cure all quick fix capsules or medications and hospitals alone. In fact, in India, what happens now is social health or public health is becoming a neglected orphan. Not just an orphan, neglected orphan. Everyone has neglected it. Let's see where India lies in happiness index. Out of 156 countries, we are in the 140th place. Afghanistan is only country below us in the Asian subcontinent. The happiness index was calculated based on these 6 parameters. And based on them, we are faring very, very poorly even in the Asian subcontinent. Look at the top 10 countries. You can see that most of them are Scandinavian countries. Because these are issues of social security and human development. Happiness you cannot produce artificially. Look at the Asian countries. Sri Lanka is better than India, several times better than India. But then somebody might say that India only gave money to Sri Lanka during the financial crisis. It's not the money that matters. It's the distribution of resources. Whatever is available, if it is properly distributed, you can achieve a better happiness. That's a lesson that we have to learn from this particular observation, rather than criticizing the people who did the ranking. Malnutrition and poor lifestyle is a deadly combination, and as a result of that, we have a package of diseases, including infections, obesity, metabolic syndrome, hypertension, all the non-communicable diseases. The same people who are malnourished, because in fact, nobody knows what exactly is a balanced diet even, leave alone access to a balanced diet or availability to purchase and consume a balanced diet. The same people who are not eating a balanced diet are exposed to all the wrongs in healthcare. And the same people are exposed to overeating, smoking, alcohol, lack of exercise, and unmanaged stress. Finally, you have a package of diseases. This is where India is now. It is number one among all the countries in terms of any disease. You cannot find a disease where we are even number two. That's where India is now. So this is a very dangerous situation. We have to improve our situation. Otherwise, we are going backwards. You name any problem, health problem, we are number one. Even starving population, it is said that 27% of the world's starving population is said to be in India. Under 5 malnutrition, also we are on top of the other countries. Debt traps after treatment, mental illness, blindness. Among all these, we are number one in corporate hospitals also, medical tourism also. And if you look at the richest people in the world, again, we are number one. And all this tell about the improper distribution of wealth and resources. This was a picture which I took when I was HOD at Calicut Medical College. The bed occupancy rate is more than 100% always. There are always floor patients. Look at the plight of this patient and the bystander. When we were students, that is some 40 years ago, in the 80s, those days, there were no floor patients. After that, the bed strength and hospital numbers, doctors, all these are multiplied at least 40, 50 times. Now, no hospital is vacant now. All hospitals are overcrowded. It also only tells that diseases are multiplying disproportionate to population growth. This is one thing which we need to address rather than just increasing the number of tertiary care hospitals and medical colleges in each district. So when India has the maximum number of diseases, what is the kind of disease care that we need? We need doctors who can make prompt diagnosis, who can offer prompt treatment in the community setting rather than sending them all to the hospitals with less investigations, have a cost-effective approach, give a person-centered holistic care, having interest in health and wellness too. But this is possible only with large numbers of trained family practitioners or the GP doctors. I have to declare my connection with family medicine. In fact, when I joined BBS, I witnessed, because I'm from a rural background, I found very good GP doctors, family doctors when I was in schools and colleges. And I joined BBS with a desire to become a general practitioner. And I had been the best outgoing student for BBS also. But because of my passion for teaching and clinical skill, that made me go for MD medicine at PJ Chandigarh. But in spite of numerous opportunities to do any DM of my choice, I left PGI without a DM in 1986 because by the time I realized the importance of person-centered care, I realized that I would only deteriorate if I focus only on one specialty alone. And after that, in 1987 itself, when I visited the Kanandevan Tea Estate in connection with the conference, I found that the doctors put in that was the British system they were following at the Kanandevan Tea Estate, which is now Tata Tea in Munnar. I found that there were 35 estates, and each estate had one medical officer. These medical officers were in charge of the healthcare rather than treatment. If any one of the employees or managers developed diseases like diarrhea, dysentery, cholera, typhoid, one increment of that particular doctor in charge of that the estate would be cut by the estate managers, estate administration. So this only tells that the doctors in charge of such a primary health center kind of setup should be in charge of their healthcare rather than waiting for diseases to come. Then, as I was working at the medical college, I had an opportunity. I was invited to the alumni meeting of the Calicut Medical College students in the Golden Jubilee year in UK in 2007. Till then, I did not have a clear-cut idea about what is family medicine or family practice. And there I found that 180 students, 170 students and their family members came. It was a huge gathering. Only two were proudly saying that I am a GP. Rest of them all were specialists. Then I thought the same thing is happening in UK also. But I found that the GPs were getting £5,000 a month, whereas the specialists there were getting only £3,500 a month. In fact, GPs are considered the most important doctors in UK and other countries. This I realized only after visiting UK. And Indian doctors who reach there will try to see whether they can become a GP, but they will find that it's impossible because they do not have the aptitude or the mindset or the opportunity. Finally, they end up as specialists. And we will think that they only have specialists like us. This is what is happening outside India. The system respects the GP or family doctors, and that is how it has to be brought up. And then I knew of its higher relevance due to the problems we faced, and I started studying pitfalls in our health system. And to complete that study, I started visiting our other countries. In fact, I went with that objective alone to 17 countries. I traveled at my own expense. And the objective was to study the health systems. This is one observation I can tell you which tells about the social aspect. This is Denmark, the Copenhagen railway station. You can see the main parking area is given to bicycle, because this is just to promote cycling, exercise, and to reduce pollution. So many things in one go by just promoting cycling alone. The entire roads in that country has cycle path and footpath separately, and you can even travel on buses and train with your bicycle. And in fact, cycles have to be parked outside the cars have to be parked outside the city, and there are free bicycles kept in the outskirts of the city. You can use it for traveling into the city. So this kind of policy changes alone can provide social health. This is to promote exercise. Same is true about dietary habits or other lifestyle habits. We need to understand the social aspects of health when we practice medicine. That's possible only with trained family doctors. So due to absence of good GPs or family practitioners, there is no organized plan to teach or promote good lifestyle habits in India to the people of India. Then I will just share the important lifestyle habits. These are the important lifestyle habits. Most important, which is eating a balanced diet every time, every day. To teach the people on what is balanced diet. In fact, in a survey, we found that 98.5% of people do not even know what is a balanced diet. So every individual has to be taught about the scientific aspects of balanced diet, not the traditional practices. But to provide good food, we need good agricultural practices also. And they should be taught about how to avoid overeating. We need to give practical tips. Again, we need family doctors. To avoid junk foods and fast foods, we need to make the people identify as what is meant by junk food and fast food. And we need to also control the advertisements, sugar industry. So that involves several departments. And people should be taught about the adequacy of drinking water, and the safety has to be ensured by the PhD, Public Health Engineering Department, not the water authority. And people should be getting potable water through the pipes. Proper waste disposal habits has to be taught to the people by segregating and disposing at the appropriate place, and teaching them about the kind of exercise that they should do. And we should provide social facilities for doing exercise. Again, to teach and create awareness, we need family doctors. People should be educated on the bad effects of these habits like alcohol, smoking and all. They should know that no amount of alcohol is safe. And to educate and to get, again, we need family doctors. And people should be taught to avoid accidents, protecting from accidents and injuries. Again, for this also, we need family doctors. People should be taught about the appropriate posture at study, work, sleep, and travel. All these need education by family doctors. They should be taught about respiratory hygiene, personal hygiene, sleep hygiene. I'm not elaborating on the minute aspects of these individual issues. even sexual health, gender empowerment, age-specific, gender-specific sex education or gender empowerment has to be imparted through the school health programs and through the family doctors to every individual. Everything, if you look at all the lifestyle habits, you find that family doctors have a role. Without them, it's not possible to achieve any of the good lifestyle habits. And to develop a good work culture, it is basically an issue of social security and good primary education, because people should be choosing the job because they love the job, not because it gives more money. So that work culture has to be developed. But that is an issue of social security and good primary education. So I'm trying to say that good lifestyle habits or the healthy habits is a byproduct of all these issues, and family doctors have a very important role to educate the people, and the social security and human development issues will empower the people even to manage stress. Though social security and good primary education are important, family doctors are important to guide the people. So basically, health education has to be given through the primary care centers, PHCs, and sub-centers, or the primary care private clinics. Who is a family doctor? It's a generalist doctor who gives person-centered care, holistic care, who is interested in prevention of disease and promotion of health, very good at clinical skill, and the familiarity with individuals, families, and the society. They can make early diagnosis with less investigations. And because they are people friendly and they connect well with people, they can guide them in several aspects of their social life. So the ideal family doctor is not just a physician, a friend, philosopher, and guide in healthcare and disease care. It's a challenging job because, and doctor, the word meaning is teacher. That word is applicable to truly to only family doctors, because only the family doctors can become true teachers to the people. And the most efficient ones should opt for this particular job, and they should be the highest paid and most respected by government and people. But this does not happen in India. And the most service-minded and those who are good at clinical skill only should go for this job. And in fact, that's what we should do at MBBS training itself. And family doctors are the only group of doctors who are going to practice medicine as an art and science, because medicine is not both an art and science. But if you put science before the art of it, we are bound to fail. In fact, you can practice medicine with art alone, as demonstrated by some of the alternative system colleagues. Without science also, you can practice medicine. That means art is very important. So family doctor is the one who is going to practice medicine with art in the maximum possible extent and with the science of it. These are the objectives of family practice: to promote wellness, happiness, creating awareness among the people and administration, and to make treatment cost-effective, affordable, accessible, and comprehensive and continuous, irrespective of age and gender, including palliative care. Why palliative care has become so important in India? Again, because of missing family doctors. It is true the doctors in palliative care are dedicated, service-minded, but even they can do their job properly only if you have enough family doctors. In fact, in the Kerala Health Policy Committee, I was a member. The palliative care volunteers were complaining that they do not have trained doctors in the periphery to guide them. So, in fact, we need to deliberate on family doctors simply because there is lack of awareness. Heart people know its relevance, everyone would have worked for it. The wrong policies and wrong prioritization of resources and the wrong advices are only due to lack of family doctors. In fact, in other countries, the chairs of doctors' organization, for example, South Africa, England, everywhere, the chairman of the doctors or associations are all the general practitioner family doctors, because they are more in number. So here in India, they are minimal, and the influential doctors are all specialists. So the policies become wrong. The wrong advisors only finally reach the decision makers and planners. And several wrongs in healthcare and medical education now is happening only because of the missing family doctors in India. We are ignoring these priorities. This is again because we do not have family doctors. Because the family doctors only will become aware of or being sensitive to the basic issues in healthcare, like malnutrition. India's biggest problem And the number one enemy is, in fact, malnutrition. We are ignoring it. In fact, there are people who estimate B12 and folic acid levels in people who do not consume any fruits or meat. We have reached that kind of stage. And this is considered safe drinking water when we are supposed to provide safe drinking water through pipes. This is our environment. And the same people who do not have these basic facilities are led into adopting wrong habits like eating more, not doing any exercise. And this is a consumerism. These priorities are ignored, and to make people aware of the priorities and to sensitize the people and the administration on priorities in healthcare, all these need adequate number of trained family doctors. We need to build a health pyramid like this, and at the bottom of it, the base of it is social determinants of health, which provides all the social health needs, including diet, lifestyle, habits, and everything. Facilities, environment, shelter, education, and that will reduce the disease burden. And then the largest number of doctors will be family doctors. They should only be sitting in the PHCs and CHCs and all. And then the generalist doctors in the hospitals, very few number of specialty hospitals. This health pyramid we are missing, and in fact, we have made an inverted pyramid in India. So all the patterns are multiplying, and there are no scientifically trained, all because we do not have scientifically trained doctors to connect with people. No competent and dedicated doctors on PHCs. PHCs cannot become true family health centers without trained family doctors. But Kerala has taken a lead to rename these PHCs as family health centers, but they are not aware of the importance of posting trained family doctors in that PHCs. Disease burden is increasing because of the absence of family doctors. Diagnosis becomes delayed, complicated, and incomplete because of absence of family doctors. And increased number of tertiary care hospitals, which is an artificially, it is artificially increased need, not arterially. It is artificially increased need because of the absence of family doctors. Same case, the artificially increased need for specialists lead to more necessity for starting more and more tertiary care hospitals. And then that leads to more need for more and more medical colleges. And that leads to increased out-of-pocket expenditure for the patients. The artificially increased need for single system specialists is all creating problems only. And finally, we have started designing medical education to bring out only specialists. It's a never-ending vicious cycle that we need to break. Nobody to guide people scientifically in India. And that is the reason also for the increasing hospital attacks and attacks on doctors and hospitals. All are due to the missing family doctors to guide the people. So all the patterns are multiplying, and people are finally guided by religious leaders, spiritual leaders, godmen, astrologers, and the consumerist forces. This is a very, very sad situation in India. There is nobody to guide people scientifically. And that alone, again, is responsible for increasing sexual violence, the moral policing, because there are nobody to guide them, educate them properly on what is the behavior, scientific behavior in public. Medical education and hospitals become industries only in India. People are actually disconnected with the modern medicine people now because of these wrong trends. Finally, the unscientific traditional practices sustain and grow in this huge vacuum. And social and preventive medicine, which is supposed to make policies, are not doing their job because they changed their name to community medicine. But one should know the facts about clinical practice. Diagnosis in any patient, even in the most complicated setting. In fact, I am working in a tertiary care hospital and I see only referred cases. Even in those patients, the diagnosis comes by good history and physical examination in 90% of the patients. In a community setting, it will be more than 99%. So diagnosis always by clinical skill. And that will be maximally used only by family doctors, and in the hospital by the general medicine or general pediatricians. So we need doctors who diagnose and treat common problems. 90% of problems can be managed at community level, whatever may be the disease. And GPs and family doctors are the most important doctors for any sensible society. But India alone does not realize that. Doctors who work in the large hospitals are less important. They are needed, but they cannot replace family doctors. Doctors who work for prevention of disease are more important. And that is why we have to show that doctor is a teacher also. Teaching about what? Not about catheterization and lithotripsy and all. We need to teach them about proper diet and lifestyle habits. And doctor has to truly become a teacher, and that's possible only with family doctors. These are the concepts of family medicine or family practice or general practice or primary care. This is what is happening now. In COVID, it was exposed very clearly. The COVID mismanagement all happened due to missing family doctors in India. We need a 360-degree vision for individual care and public health. And GPs and family doctors only can get that 360-degree vision. There are numerous cures and remedies, but do not see the real problems, that is malnutrition, poor lifestyle as the causes for it. It is like comparable to 6 blind men palpating an elephant. They arrive at their own conclusions and then dictate policies and plans and management protocols, and the governments are misguided and the resources are misdirected, and we fail to achieve proper health care. In the name of science, we fail to see the major macro issues, that is malnutrition and poor lifestyle habits. And we even the link to microscopic issues to macro issues we forgot to identify. Because, for example, vitamin D deficiency, it's not an issue of sunlight. It's an issue of malnutrition. Even that is missing in India. And why is PG training needed in family medicine? MBBS and a work experience was enough till 1970s because there were no PG training in specialties. So all the MBBS doctors naturally worked to become GPs, and by 5 years or so, they became very good family doctors or GPs. But that's not possible now. Now it is impossible because the students now go to medical colleges with a desire to become PG, and they spend their time in entrance coaching centers and not learning about the clinical skill that they are supposed to get. Even when we were students, we actually wanted to become GPs, and we were after all the good teachers to learn maximum skill. But at the end of 5 years, we realized that we are not good at doing independent practice. We need more experience. So that experience was needed even at that point of time. But they had an opportunity to get it by working for 3 to 5 years, and they became very good GPs at those days because none of them went for PG training in other branches. Now the things are different. Even that once they do not focus on clinical training, they are always bent on becoming a single system specialist. Such people can never become GP without a 3-year training. This simple fact is not understood even by the National Medical Council chairman or the policy makers in India. So the MD or DNB is not just to give a degree, it is for capacity building, to improve their capabilities to work as an independent GP or a family practice, to make them competent and confident, and also to become faculties for training other students and the MBBS students in the medical colleges. Can the MBBS doctors become family practitioners? Yes, but it was true once. That too required 5 years of experience. But now at this moment, it is no. Nobody can become family doctors without a training. Nowhere in the world, without a 3-year training after the undergraduate training, they are allowed to do independent practice as family doctor. Nowhere in the world. Then why should India alone have family doctors without training? Actually, the students now are wasting time in entrance preparation. Huge waste of manpower. There are about 1 lakh seats, MBBS seats, 45,000 PG seats. That means 65,000 or maybe 55,000, 45,000 PG seats. That means 55,000, not 65. Almost 55,000 jobless MBBS doctors we are creating annually. I call them null doctors. They're neither here nor there, and they are considered GPs by some people in India. The policymakers have considered these null doctors as GPs. It's a wrong trend. All the MBBS doctors wanted to become single system specialists, and that is responsible for all the issues plaguing healthcare in India. We need to liberate medical education from large establishments. This was one statement made by somebody like Dr. Devi Shetty, who is a cardiothoracic surgeon, advising the government. And what he said was, we can use all the hospitals for training specialists. But that particular doctor didn't know that it is true, we can liberate medical education from large institutions. We can use general hospitals and even CHCs and PHCs, but to bring out family doctors. That's the point we have to stress, at least from now on. The India does not have front philosopher and great kind of doctors. Till 1947, all MBBS doctors were working as family doctors. Those days, students had the objective to work as family doctor. After MBBS, by default, they were working only as family doctors. And finally, they matured naturally into good family doctors. Even then, MBBS was not enough. We all knew after passing out MBBS those days. This is the reality. But nowadays, the present day MBBS student can never become family doctors without minimum of 3 years training. So we had no policy, and slowly what happened to us, all the MBBS doctors, though they were working as family doctors till some 1980s, slowly, because the government did not have policies, slowly because they started disappearing, and finally all were extinct. There are no family doctors now. So the government does not promote family doctors. There is lack of awareness. Now people ask, what do you mean by family doctor? Why do we need them? I am fed up with answering this question to everyone, including responsible persons. Once I had to answer this question to a vice chancellor of a health university. What is the difference between family medicine and community medicine kind of question? The resistance to promote family medicine is simply due to this lack of awareness also. Look at this. Recently, there was a write-up in Economic Times. The one person is recommending to the government to increase the specialty seats. These people are misguided in the governments. Enough and more MBBS seats we already have. We have enough and more medical colleges now. But we are failing to produce doctors for India. We are producing doctors for other countries. Doctors to become specialists, to supply to the increasing need of rapidly multiplying corporate hospitals, which are tertiary care centers. We failed to build a base for scientific modern medical practice. That's the reason for all unscientific practice in the society. The cry for more medical colleges and more specialists is by the market forces, which are trying to supply to the increasing need of the market trends. They cite shortage of doctors. Who are the short? Where is the shortage? Shortage is only for family doctors. So we are creating an artificial shortage, and we are unnecessarily wasting manpower. We failed to realize the power of organized primary care and a referral system. We left everything to the market forces in India. One patient nowadays needs 2 to 3 or 4 doctors at a time, even for minor ailments. In fact, the patients have started using tertiary care hospitals and corporate hospitals for their primary care now. One patient needs 3 to 4 doctors. Disease care is almost always now institutionalized with freedom for doctor shopping. Every patient has the freedom to choose a doctor of his choice. And that has created an artificial increased need for specialist doctors. Even if we convert all the 1 lakh MBBS doctors into specialists, it will not save the people of India. This is a reality. Unless and until we make majority of them family doctors. So 1 lakh MBBS doctors are competing for the 45,000 specialty seats. It was 35,000 till a year ago. So 55,000 MBBS graduates every year are wasting time and money to become specialists. It is impossible for every patient to consult multiple doctors for their problem. This reality has to be conveyed to the politicians and leaders and public. And we should tell them that we have to have family doctors, and the people should be consulting designated family doctors only, as is happening in other countries. When they refer only, these patients should go to hospitals and specialist doctors. Specialists should be working in hospitals, and they should accept only referred cases. They should never accept cases coming directly to them. So there is an urgent need to train the remaining 55,000 doctors to become family doctors. Let there be 45,000 specialty seats. No more increase in other specialties. So remaining 55,000 doctors have to be trained to become family doctors urgently from now on. If we start now, after 3 years, we will start getting enough family doctors. We can easily solve all our manpower problems in healthcare in India by this single measure. We can use all the district hospitals, all the general hospitals, including private hospitals, taluk hospitals and CHCs and PHCs for their training, and we can provide manpower also by the trainees. That's the only way to liberate medical education in India from the large institutions. Medical family doctor is a challenging job, but it's the most enjoyable to those with aptitude for medicine. That's the point we have to keep in mind. The students should clearly know that that's the most enjoyable job for anybody who has aptitude to become doctors. If you look at the healthcare scenario or disease care scenario in other countries, 70 to 80% doctors are family doctors. In Canada, there is a rule actually. Now, almost 80% doctors are working as family doctors. The streams are separate. After a BBS, majority students willingly go for family practice because that is the most attractive. That's the most desired job for doctors. And they're, in spite of having a low disease burden, they have provided good social security and human development initiatives, and their disease burden is low. And such countries have 80% doctors working as family doctors. What is happening in India? Our disease burden is the highest, and we are bringing out only specialists. You can imagine the confusion that can happen in India. So GPs and family doctors get more respect. They give more salary to the GPs in other countries. This is happening in all the countries. All the countries have it because it is a social need. Countries from which we should learn are UK is the base model for family practice in UK, though it has started deteriorating. The Scandinavian countries, Canada, Australia, Cuba are models which can be copied, but again, problems are there which we can rectify. If you look at USA, the worst model in the world among the developed countries, it's a non-system. Everything is private. Even that country has 80% doctors working as generalist doctors. They don't have that craze like India. Even in that country, India is following USA, but at least USA we must imitate. In the USA, 40% of doctors are GPs, 40% are internal medicine. Only 20% are specialists. At least we can imitate that worst model in the world. So family medicine in other countries consider they are involved in health of the family as a unit. They give continuous and comprehensive care. They look after all individuals. They have to register with one GP all families, certain number of families. It may be 250 families in some, and there is no direct access to specialists in any of these countries. In Canada, the disease care system is for the people. India and USA, the disease care system is for the doctors and the hospitals. Most important doctor in the society is a family doctor in such countries, and they have a 3-year training after UG training to become a family doctor. No country allows MBBS doctors to directly become family doctors in anywhere in the world. The family doctor stream is separate, and we will not hear of anything about family doctors when we visit other countries unless we ask about it, because it is for their people. They will not market it. Equal status and opportunity to go academic and or do research in family medicine stream. How would they function? They all function as part of the government system. At least we must have private family doctors as in USA. In all the other countries, the family doctors are working as part of the government system. All are working for the government, and some of them rarely runs private clinic. Each person is having a family doctor, and unless that family doctor refers, they will not reach a hospital. And there is universal insurance cover, as in NHS. 10% of their income is given to NHS, and that is used for providing universal cover. Everyone will get the same kind of treatment, same respect, no differentiation at all. And in Denmark, though it is similar to UK, the GPs are running private clinics for the government. The fees is given by the government, but the patient will get everything free. In the USA, private clinics by doctors, and there is no insurance for 50 million people in USA. This is this is a country which India is copying, and we are getting worse situation than even USA in India now. There is a 3-tier referral system. Family doctor is a key player in all the countries. In Denmark, I forgot the number. I think it is 1,500 individuals with one family doctor. In Cuba, it is 250 families. You will be surprised to know that I even visited Cuba to study about the family medicine system. It's a low resource country, but still they have very good healthcare. They provide house visits also. They supervise health status and sort out family issues. And they lead a health team, and they are responsible for health and disease care irrespective of age and gender, which includes obstetric, geriatric, psychiatric, and palliative care. But also there are nurse practitioners. They provide the walk-in clinics. Patients cannot directly go to the GP or family doctor without an appointment, but the walk-in clinics are run by nurse practitioners. That also is an important issue which we have to take care of. You can, in fact, we have the subset days where we can put the nurses in charge of it. They can be part of the health team and they can look after promoting health and wellness also. In USA, it is rich only will get treatment there. Everything is under private system there. Still, 40% doctors are family doctors and 40% are internal medicine. This came in the New England Journal of Medicine. Some good Samaritan doctors write about their pitfalls, but we fail to see that even. We promote only the bad things in USA. The new brand of internal medicine, they call it as hospitalist doctors. 18% are belonging to that category. Only 22,000 are specialty doctors in the USA. It's a totally disorganized system for profit. It is working for profit mostly, and that system alone is copied to India, but it is worse than USA. But there is confusion about what is general medicine and community medicine. General medicine is generalist doctors working in the hospital setting. They can be called as hospitalists. They also provide person-centered care in a hospital setting. Family medicine doctors give person-centered holistic care in a community setting, irrespective of age and gender. They look after a certain specified number of families or people. But in a internal medicine, the people may not be the same. They keep on changing. Community medicine is a misnomer. Actually, it is social and preventive medicine. They are for policy making. They are actually higher in the ladder, and they should be there in the medical colleges for social medicine, social practices. But the insights they use should be from family doctors. These days, actually, the insights the policymakers get is from super specialty doctors in India. That's why all the policies are going in the wrong direction. And in fact, the family doctors should be the advisors to the government machinery. They are the liaison between doctors and the government. They have a very important role, but India has neglected that too. So coming to the problems and solutions to the disease care in India, we need to promote family doctors, post them, trained family doctors only in PHCs. And we need to promote generalist doctors in the hospital, that is internal medicine, general pediatrics, kind of doctors or hospitals. We need to give better salary to family doctors as in other countries, and we need to introduce a referral system in disease care. So these are the solutions, and that was the background for filing the public interest litigation. We need to create awareness on all the health needs, and we have to empower the people to have regular access to all the health needs. We have to provide all the positive social determinants of health to every individual. That alone can reduce the disease burden. Only when the disease burden is low, the disease care machinery can sustain. And good primary education is important to instill human values, because humanness is important in looking after health of the people. School and college health programs can concentrate on providing health education, and all this is possible only when majority doctors are working as trained GPs or family doctors. This is the social determinants of health. You can see that all of them are social issues. When you have social determinants of health, you will get low disease burden. In that situation, only disease care machinery itself can sustain, but the background of it needs a corruption-free society, and family doctors are also part of the social determinants of health. That's one thing we have to keep in mind. Because why do we need family doctors? 90% of illness can be solved in the periphery. They don't have to go to the hospital. Only less than 9% of all patients should reach a hospital. What is happening now? all doctors in India should have family medicine orientation also. And that is why we need Department of Family Medicine in each medical college. And every medical student should be aware of what is family medicine and what is their role in the society. But the paradox is, when people do not have family doctors in primary care, people in administration and doctors are unaware of its importance. There is no accepted family practice guidelines now in India. People ask for cath labs, dialysis centers, and transplant centers, and these have become public health activities now. Even emergency medicine and palliative care, they are aware of. But the most important requirement, that is family practice or general practice, no one knows. But it's the most important. Unfortunate situation in India. The need for family medicine, we are talking about because as if we are aware of it. Actually, nobody is aware of it. There is no point talking about family medicine, thinking that people are aware of it. We have to tell them what is it, why is it needed. Then only there is any point in discussing about it. Therefore, we need to have strategies and policy changes. We need to kickstart family medicine boldly with a firm determination because nobody is aware of its importance. People do not know that it's important for them. So no point discussing as if it is already there in India. So I come to the family medicine department at Calicut, started in 2012, but in 2016 it was under threat of closure because there was no professor for the department. That's at the point I offered my service voluntarily, and I worked for 2 years full time and got recognition for the department. Thereafter, I still work as part time, and government in fact offered me salary. I denied it because I wanted to do it as a voluntary service. That's why kind of involvement that I have with the family medicine department at Calicut. So this is what happened. The works that we have done at family medicine department, we have started a family practice unit in the periphery with 250 families adopted. We have adopted one CHC also, one Taluk hospital also. Our residents are posted. They gave elderly care, palliative care. And some of our doctors in PHCs have started making differences. And the research done by our PGs got best thesis awards. And we are the doctors in the department are into training for other doctors also. They're also doing advocacy work for family medicine and teaching people on good lifestyle habits and wellness too. This is a department, the faculty and the residents. And this is the health unit, family health unit, where 250 families are adopted. And recently only we got an independent ward. But again, there are difficulties in admitting patients due to the lack of permanent faculty. We are still struggling for it. And MD residents are posted in this CHC. And there also, for 4 months, they are posted there. And the care in the CHC also is improved with their presence. That not only that they learn from there, they also contribute to the patient care in these CHCs. In a Taluk hospital also, they are posted for 6 months. Again, the manpower of that hospital improves when you provide large number of family doctors for training to these CHCs and PHCs. And we adopted 250 families in a nearby area, and that is the family health unit attached to the Calicut Medical College Department of Family Medicine. This is Dr. Vinny is taking classes for the residents there. The residents do home visits to the families which they are looking after, and they prescribe medicines, tell about lifestyle modification and other activities. And the patients are very happy. People are very happy there. They don't go to any other hospital these days. They even make house visits to provide elderly care and for bedridden patients. This is what palliative care is all about. So the postings they have, in addition to posting in general medicine, pediatrics, gynec, orthopedics, psychiatry, in addition to all these, they have 4 weeks of community medicine, 4 weeks in palliative care, and the department is giving family medicine orientation programs to undergraduates and induction classes for UG students for family medicine. The department is doing, and that has motivated some students to take up family medicine. Now, what is happening is students with very high ranks are coming to join family medicine. That means students were unaware of its importance. Once they realize they prefer to become family doctors, we need to provide more seats and we need to build a career trajectory for them. So doctors trained in family medicine are making a difference in the PHCs and CHCs. Some of them are getting best PHC awards also. These are some of the examples. Dr. Vineet, who was here, joined PGI, started a department itself there. Dr. Salila, Best PHC Award. Bijoy, Best PHC Award. Javed and CHC had conducted deliveries too there. And others have joined PHCs recently. They are all making a difference in the PHCs. Some are successfully running primary care clinics on their own because they did not get a posting under the government. This is one family health center. In fact, this got a Best PHC Award, but this doctor, this was one of our PGs only. And this is again Dr. Bijoy's PHC, which is now called Family Health Center. But Kerala government has got a commendable initiative in upgrading facilities in all the PHCs. They have renamed them as Family Health Centers. But the only mistake is that they forgot to know that they failed to understand that trained family doctors should be employed in the family health centers. That's the only mistake which now we are trying to overcome by sensitizing the decision makers. That's where the PIL is going to help us. So the hurdles and promises are very important to be known. The lack of awareness is a major stumbling block. I was into creating awareness for the last 15 years. In fact, I had been taken several classes, more than 1,000 classes, awareness classes I have taken, and people are now sensitized, wrote books and wrote in social media and conducted seminars, motivating students. I even traveled to Madras Medical College in St. John's to brief students on the importance of family medicine. But the problem is lack of support from administration, lack of faculty appointment. And we need to sensitize Niti Aayog, NMC. They have to take initiatives to make policy changes. We have to make Department of Family Medicine mandatory for recognition of each medical college. This is a very important step. Ultimate objective is to have a situation where MBBS seats are equal to PG seats, because the remaining 55,000 seats can be allotted to trained family medicine doctors. So these are the suggested policy changes, which are the grounds for public interest litigation also. Large numbers of trained family care doctors to be brought out. They should become agents of change for a better India. Their role as front philosopher and guide will be used for the people. And let us make Department of Family Medicine mandatory to kickstart. This will act as a catalyst for training and motivating and guiding the UG students too. The JRs can be deployed to all the PHCs and CHCs during their training. And it is there in the curriculum that will improve the functioning of these PHCs and CHCs as well. And we need to start DNB program or diplomas programs in the district, taluk, and private general hospitals, including. The step 1 to 6 itself will improve the efficacy of the health system. Experienced family doctors to work as adjunct faculty there, even if they are in private sector, can be used for training all the PGs posted in private hospitals. MD and DNB diploma or diploma in family medicine holders alone should be posted to PHCs or family health centers, at least in future. Family doctors need better incentives because people need them. It is truly for the people. Why family doctors, GPs enjoy better status in all the developed countries? This is the question that we have to project to the public and to the administration. Let us not deny this privilege to our people. So long-term objective is to have, we have 1 lakh MBBS seats, but PG seats are only 45,000. Remaining 55,000 MBBS doctors can be transformed into family doctors every year as a long-term objective. It can be achieved if we start now. 80% of doctors should be working as family doctors for India. And that should be our major goal. So why the PIL? PIL for these larger objectives. In fact, we could convince the PIL was drafted beautifully by an academic drafting by the advocates involved, and the Honorable Court was convinced of her arguments. And only thing, they noted all the important points, and being a policy matter, they issued a mandamus to the government to intervene. So it's not a small thing; it's a big thing that we achieved. And we can achieve Department of Family Medicine as a mandatory requirement for recognition of all medical colleges if you go after this PIL in a very active manner. So this was the court mandamus given. to create mandatory family medicine departments in all medical colleges. The mandamus was given to Union Government, NMC, and State of Kerala, and Kerala University of Health Science. Now they have to respond. They cannot say no, because if they are socially conscious, they will never say no to that direction of the court. Henceforth, post in PHCs, this is there in the judgment. I can give the copy if you need. Henceforth, the post in FHCs must be filled only with doctors who received specialized training in family medicine. It's not, they cannot dictate. They are suggested to look into this issue. But the government cannot say no, no to it. They should be having MD, DNB diploma. To issue a mandamus to State of Kerala and Kerala University of Health Science, directing that existing doctors appointed in family health centers in Kerala must be given adequate in-service training leading to diploma or degree in family medicine. In fact, while giving the judgment, the court has drafted all these important points. They distilled all the important points in a 60-page document and then gave the judgment. This is the exact wording written in the judgment. Efficient primary healthcare system with family doctors as the dominant players can help in focusing on health and wellness scientifically and reducing disease burden and the patient load in tertiary care centers like medical colleges. Family doctor is a doctor. This is the wording of the judgment. Family doctor is a doctor who works in the community sector and acts as the doctor of first contact, providing continuous and comprehensive care, including emergency and palliative care, to all people, irrespective of age and gender. The judgment has taken note of this point. Trained family doctors deployed in community setting, including rural areas, will reduce the disease burden by educating patients about best health and hygiene practices, and also reduce the unnecessary hospital admissions and emergencies needing hospital-centered care. Family medicine doctors also called us, they also noted the names also. GPs or primary care doctors play a very important role in prevention of disease as well as promotion of health, thereby reducing disease burden and healthcare expenditure. Other countries have introduced family medicine system decades back. This also has been noted by the judges. India stands as an outliner among the world countries by its failure or neglect to promote the most needed class of doctors for the society, that is family doctors, neglecting the fact that health is a fundamental right and human right guaranteed under the Article 21 of the Constitution. Court took note of the submission that socioeconomic determinants of health, of which people may be unaware, such as access to proper diet, clean water, sanitation, affordability of hygienic surroundings, etc., play a determinative role in overall health. This also people will be made aware of by the trained family doctors. We have seen during COVID-19 as to how marginalized sections are disproportionately affected. The court noted that the specialties focus on specific diseases and the solutions in a hospital setting rather than general health and wellness in the community setting. Focus on wellness and health is the domain of family medicine, a field whose potential and value is not adequately understood or developed by the country. These were the points noted by the Honorable Court. The court took note of the violation of recommendation of the Ministry of Health in 2002 that 25% of all this is noted in the judgment. Postgraduate seats should be in family medicine, and that no new postgraduate seat should be started in any medical college unless this condition is fulfilled. This was also highlighted in the national policy in 2017. This is the wording given in the judgment. However, no steps have been initiated to start courses in family medicine in our medical colleges. Despite being the best healthcare model for the rest of India, the state of Kerala has not shown the requisite level of interest in developing family medicine as a field of study or practice. These facts were represented several times, but they were not considered so far. Hence, the petitioners sought intervention of the court. This is the exact wordings of the judgment. So, finding that is a PIL and the result. Now, finding faculty for training. Till we get family medicine, so we have to presume that it will materialize. It has to materialize, but because our people need family doctors. Till we get family medicine trained doctors, we can make alternative arrangements. We cannot start a program with formally trained faculty. Like, for example, when we started DM courses in India, there were nobody with a DM. So we cannot have trained family doctors at this moment to work as faculty for family medicine. So you can deploy people with interest in family medicine from other specialties like internal medicine, pediatrics, gynec, surgery including. The most important first step is to create faculty posts in each medical college. Once 2 assistant professor posts is created in each medical college, that will be the first step. Let us work for that. Train the existing doctors in PHCs, CHCs across the country in family practice guidelines. National board has the mindset now, because I was part of the team for making curriculum for the national board, and they are very much in favor of giving training even in diploma course, starting diploma course in general hospitals, district hospitals, and taluk hospital, including private hospitals. CHCs and PHCs can also be used for training to get exposure. We do not need more medical colleges in India. We can use all the district hospitals, private general hospitals. All these places can be used for training. That alone will improve the health system in India. We can make it the best in the world. In fact, if you start family medicine training, and in another 5 years at least, we can start improving the health system in India. In fact, when I started writing about family medicine, somebody was commenting that he is marketing family medicine. So what? In fact, I am marketing family medicine. It is for a better India. It is for our next generation. I do not gain anything by marketing family medicine. I'm not a family doctor anyway, but I market family medicine because it is important for the people. It is for the next generation. Thank you. Thank you for the patient hearing. And if you have queries, please ask. We will discuss on the...
Thank you, sir. Thank you very much. You clearly enlightened us regarding the present health situation of India and the methods and ways to improve our health system. Your words will surely be a boost to all the doctors over here to create a healthy India. If you have any queries, you can directly ask or put in the chat box.
Any questions? I'm trying to see whether there is anything in the chat box.
Hi, Doctor. I am Dr.
Hi.
Joseph Lucas from UAE.
Very good. Nice to see you.
I was so happy to listen to you, and really, you have just done a great mission, a great startup for a great mission. I worked with Dr. Kashi Vishweshwaran as a junior lecturer in the Kottayam nephrology department, and I was an ardent fan of pursuing my career in internal medicine and nephrology. But destiny, I was appointed as the lecturer, but there was some issues related to reservation and all. I couldn't get my appointment concurred by the authorities. Kashi sir wanted me to be his protege in Kottayam Medical College during that time. He was running a solitary department. Then I took my passport. I flew out of the country. I reached UAE, where I wanted to continue my internal medicine. But I was introduced to a new system called family medicine by the government here. And by God's grace, I could specialize in it and be a trainer myself. And past several years, I am practicing family medicine and a medical teacher in UAE. And right now, I'm in the private practice, but 23 years I was in the government practice and in the faculty of the family medicine UAE University. So I'm just not speaking about myself. It was an eye-opener for me. When I flew out of the country, I came across what is family medicine. Met some of the most important personalities of family medicine in UK, Canada, in the GCC countries and all over the world. God bless you, sir. All the moral support with you. Whatever inputs I can give from here, it's my pleasure and privilege to offer you my support. And it was a gracious, wonderful presentation, sir.
Thank you. But take care to tell about our decision makers whenever you get a chance that this is the most important step for India, that we need to start family medicine department in each medical college. And the first step is to start create 2 posts of assistant professor in each medical college. That is mandatory to get a recognition. That must be the first step.
I'm talking with my friends in IMA.
Okay.
And
thank you.
Yeah, thank you, sir.
Thank you. Thank you.
Hello, Dr. Sasidharan. Hello.
Hello. Hello.
I'm Dr. Gopinathan. Hope you remember me.
Definitely. I remember you very well.
Now I am in Chicago for a vacation with my daughter. And your presentation, a very excellent presentation, I think. To be an eye-opener to all the concerned administrators. And I think IMA can take up the issue and also our members are there in NMC. Also, we can pressurize them to have a policy change so that the country will be benefited. Definitely, we will take up the issue. As far as I am concerned, whatever we can do in IMA, we will ask them to approach the government. And you have done a right thing that giving a PIL and the court is now directed. So the government has to consider this and come into play to implement that. We will see that it is implemented. Anyhow, this is a very nice presentation. Thank you. Thank you very much.
Thank you. Thank you all.
Good evening, Dr. Dr. Speakers. Dr. Anish.
Very good. Nice to see you, Dr.
Yeah, I could not hear the earlier part because I'm in the clinic. But hats off to you for your single-minded crusade against for the family medicine and social health. What we need is, of course, what you told, that we need a paradigm shift from our disease-oriented medical education to preventive medicine and social medicine. That we need that type of approach. And one thing that I was worried, I have a concern about is the MBBS graduates. Usually, when they graduate, they got the main aim is to get a post-graduation. And when we start a post-graduation for family medicine, how many will go towards it? Can the government make it free? Free means the lower cost, like in most medical colleges, especially the private medical colleges, you have to pay a higher capitation fee and, of course, the other fees.
I think the question is
clear.
What
about the fee structure that you? I think we should.
Yeah, definitely. That is a point. But I will tell you about the response that I got. I have taken classes for. Please mute. Please mute others. So, in fact, I sensitized the students in 3 different colleges. And every year at Calicut Medical College, I am sensitizing MBBS students. And now the students are coming willingly to take up family medicine. They are very much interested. They are very much interested. Even at Madras Medical College, I addressed a batch of 200 students. In the beginning, none of them raised hands for opting family medicine after completing MBBS. After my 1-hour lecture, about 70 to 90% of them just raised their hands. If given an opportunity, they will take it. So that's a kind of response once we sensitize. To sensitize the students itself, we need Department of Family Medicine in each medical college. Once they're sensitized and motivated, they will take up. In fact, now very good students with higher ranks are coming to MD Family Medicine at Calicut. This is another positive development. So the government has to step in by posting them in PHCs and CHCs and giving them better remuneration, better facilities. Because that's what people need. Why should the government reject them? Government has to step in. So the pressure from our people, the IMA has to be to the government to improve their salary and remuneration. Once that, the career trajectory will be built, and then more students will opt it, and we can train 55,000 MBBS students every year into family medicine. And so that we can post all of them to all the PHCs, and then our healthcare and health system will improve. That is a definite possibility. It is possible, provided we have the determination.
Thank you.
Thank you.
Thank you.
Any other question? Dr. Vineet is there.
Hello, sir.
Dr. Susan Jacob, please.
Hi, sir. Good evening, sir. Sir, I'm in Chennai. I'm in Tamil Nadu. In Tamil Nadu, when I inquired, there are about 40 diploma seats in family medicine, which are trained in different medical colleges in the district. So they are mainly appointed under internal medicine, all these students. Recently, we had a family medicine conference. So there are around 40 seats. So when I inquired in the department, they said that out of the 40 total seats of diploma in Tamil Nadu, only 23 seats has been taken up this year. So the question that was towards me when I put forward the proposal for an MD seat or starting of family medicine is that even the diploma seats, about 50% is only occupancy. So why do you need to start up a family MD?
Okay. I'll tell you the reason is
Lack of awareness.
over the last 5 decades, people in India have forgotten what is family medicine. And the administration does not know it. Doctors do not know it. The principals and VCs do not know it. So first and foremost, we have to convert. That is why the PIL we have to do. Now, nobody can say no to it. Once a department is created, we will have more opportunities for training. Then the next step is to make it mandatory that only trained people will be posted in PHCs and FHCs. That has to come as a mandatory requirement. Why should? Because now I see all the PHCs and CHCs in Kerala. Students come after orthopedics training, they will take leave and say, go. Another will come after cardiology training, they will go. Nobody is there in the PHC and CHC. Or an MBBS person comes and joins there and studies for entrance preparation. What is the use? So let us make it mandatory that students or doctors posted in PHCs and CHCs at least are trained in family medicine. Unless and otherwise they are trained in family medicine, they should not be posted to FHC and PHC at least. This should be mandatory. In fact, the court has directed that also in the present judgment. That is, we have to take up that judgment to the higher level. You can use that judgment.
Okay, sir. Okay. Sir, you started this PIL as a NGO organization, that's a Social Health, One Health.
Yeah. Because in fact, I took almost 3-4 years to convince the advocates regarding the need of it. That is a kind of involvement they are also had. They are now very much aware of it. So when they went with this PIL to the judges were so convinced. That's why they wrote all these in the PIL. Being a policy matter, they cannot tell that it should be started. They have directed it to the government, but now the governments cannot say no to it. It is drafted in such a way.
Sir, due to lack of my knowledge in the law and all, this PIL, I can use it for the Tamil Nadu government also?
Definitely, because it is given to the union government. Okay. Though it is not binding on Tamil Nadu government, union government it is binding. Kerala government it is binding. So you can use it because it is to the union government.
I can put this as a reference.
Definitely you can put it as a reference.
Thank you, sir.
I can verify with the advocates and get back to you later.
Okay, sir. Okay, sir. Thank you, sir.
Any other questions?
Sir, good evening, sir.
Good evening.
Sir, I am a student, as Dr. Susan Jacob spotted out. I am a student of Diploma Family Medicine in Tamil Nadu. I am from Malappuram. Actually, sir,
please.
Actually, now there is a very good acceptance. Even I was joined in last year. We have in our medical college 23 seats of Diploma Family Medicine. I think Tamil Nadu government has better they have come somewhat better than far better than Kerala, I think, because they have started in all government district hospitals. They have started seats and new medical colleges our medical college is newly formed, upgraded from district hospital to medical college 2 years back. There are no house surgeons, there are no PGs. So they have started with the 23 seats of Diploma Family Medicine. Last year, only 11 were joined in my batch. But this year, 18 people are joined. And just I wanted to add that into it. If such developments comes in Kerala also, that have been much better.
That is it, because we have to work for policy changes, and this PIL judgment will be a stimulus for that policy change. That's what we are hoping. Thank you. Any other questions, comments? Somebody has asked me to share the PIL. I will share it. Please ask.
Yeah, thank you. This is really absolutely fantastic work, sir. Many congratulations for what you have done in Kerala. But what you have done in Kerala should actually happen all across India. So I'm wondering whether you've had the opportunity to speak to the Niti Aayog, the National Medical Council, and the IMA And what is the response that you have received back from them?
I will answer that because I have been writing repeatedly to the Niti Aayog, NMC, and IMA, and during the last 10 years. And finally, Niti Aayog got convinced and they called a meeting. And I made a presentation to a very high power committee of Niti Aayog, NMC, directors of AMS, and health secretaries. It is a truly high power meeting. And all of them are convinced on the need to start family medicine in India, except the National Medical Commission chairman. He said MBBS is enough. So there is only, except one person, all of them who are decision makers to the government of India accepted my proposal, except the National Medical Commission chairperson. So somebody has to pressurize National Medical Commission to remove that block at that level. Otherwise, it is moving forward.
And thank you, sir. And a lot of support from our side. I have worked for 15 years in the UK and I've seen the GP system over there. I'm an advisor in a small country in WHO in Timor-Leste. And the one thing I've been advising the government all the time is if there is one and only one specialty you need to promote, it's family medicine.
That is
for
it.
all
That
the
is it.
reasons that you have suggested, for all
That
the
is
reasons.
it. That is
Absolutely.
it.
If you have to have only one, it has to be family medicine.
Yeah,
So
if the
fantastic work.
Thank you so much for that input. Please pass on this message to the decision makers in India.
Absolutely, sir. We'll do in a power.
Definitely.
Sir, how can we get that judgment PIL on PIL?
I can give a copy if you give the email or WhatsApp number. I can share it to all of you.
Okay, sir. Thank you very much.
Thank you. Any other comments? Dr. Vineet?
Yes, thank you, sir. Good evening, all the delegates. So let me add upon that family medicine finally, after all these years of advocacy, especially by Dr. P K Sasidharan, family medicine has gained a solid movement. And let me add upon what Dr. Vinay has stated. The Government of India, especially the Niti Aayog, they are starting family medicine in 6 institutes of national importance. That is, the first started AIIMS Nagpur, AIIMS Rishikesh, AIIMS Bhopal, AIIMS Jodhpur, and one more AIIMS. So the family medicine, MD family medicine, will be started in the next cycle. That is, we are expecting MD family medicine by July cycle of AIIMS. And this is somewhat different from NMC. So we are still trying to convince NMC, because NMC is in charge of the government medical college, and all these institutions, because they are institutes of national importance and they are self-regulatory bodies, they can start MD family medicine. So we are expecting MD family medicine, and there is a solid curriculum for family medicine, which is expected to meet the low resource states, especially we have low resource states in India. So with all these years of advocacy, so we have gained a momentum, and definitely this PIL would help us to implement these in other states and to pressurize the government of India and NMC. Thank you.
Thank you for the information of people who are here. Dr. Vineet was our first MD pass out from Calicut Medical College, MD Family Medicine. Now he is faculty at the PGH Chandigarh. And it's for the information of those who are depressed about taking family medicine. It is there. You are going to have a wonderful career ahead if you take up family medicine. This is one thing I can promise now. Even my daughter-in-law, after listening to me, has taken family medicine. So don't get depressed by joining family medicine. At least some people still think that it creates, there are some problems. It will not be there.
Sir, people like you talking will increase the morale of
that is it.
Yes, sir.
That
definitely is needed, especially when first thing is among the MBBS students, we need to create awareness, and eminent people like you, when they speak up for that, the morale of the students, that's one thing we always like. When we consider ourselves as to be low, then
don't do that. Don't do it. In fact, you are the most important doctors in the society. I consider family doctors as the most important, most superior doctor among the doctors. doctors among the doctors. So that's how we have to look at it.
Yeah, thank you, sir.
Any other question or comments? Otherwise, can we wind up? If there are no more questions, I think we will wind up. I thank you all for the patient hearing and very brilliant suggestions. I thank especially Dr. Vinay Botra from UK and others, Dr. Vineet and all those who contributed and given valuable suggestions. And it actually increased my confidence in going ahead with this mission. Thank you all. Let us wind up. And thank you.
Thank you, sir.
Thank you. Dr. Shabira. Anybody winding up?
Shabira?
Please. Okay, Dr. Adira is there. Dr. Adira.
Sir, good evening, sir. Today's discussion was truly very informative, or rather, I should say, enlightening to all of us, sir. I sincerely thank Dr. P K Sasidharan, sir, for all his efforts in establishing family medicine departments in all medical colleges. And I'm very happy that the court has responded positively in this matter. I appreciate, sir, for his tireless work towards the betterment of society. And I should say, I see nothing but humanity in everything you do, sir. I also thank all the participants who joined us today for their support and interest. And last but not the least, I thank the Department of Family Medicine, Calicut Medical College, for hosting such a valuable discussion. Thanking everyone once again. Good night.
Thank you all. Thank you. Good night.
Good night, sir.
Good night. Thank you. Thank you.